Hello, my name is Dr. Logan Gibson, and I recently received my PhD in behavior analysis from the University of North Texas, where this study was conducted. First, I'd like to thank SPABA for acknowledging and supporting our work. I'd like to thank Doctors Manish Vaidya, April Becker, Stephanie Gonzalez, and Joe Dracobly for their guidance throughout the study, as well as my co-author, Allison Alonzo. Study's titled Improving Dysphagia Assessment Through an Electromyography-Informed Reinforcement-Based Strategy. Dysphagia is marked by difficulty or the inability to swallow, which can lead to malnourishment, dehydration, choking, and hospitalization. Training of the suprahyoid muscles, among other lingual muscles, has been demonstrated to be effective at increasing lingual strength, thereby improving swallowing pressure, airway protection, and lingual volume. Furthermore, therapy interventions aimed specifically at the tongue press exercise have demonstrated effectiveness toward that end. A critical requirement of any neuromuscular training intervention is establishing an accurate and reliable reference value on which feedback protocols can be based. These values are essential for establishing clinical goals, evaluating the effectiveness of treatment strategies, maintaining motivation, and making decisions about the return to normal activities. While historically relying on verbal encouragement and self-reported measures like perceived exertion was necessary due to limited technology, modern equipment can begin to address the challenges of objectively measuring responses that were previously inaccessible to external observers. Surface electromyography, or SEMG, a technology that allows the user to observe muscle activation by measuring the electrical activity of motor control units, can address historical limitations and allow for the application of behavioral interventions of targeting covert physiological responses. Today, practitioners have access to SEMG and biofeedback, and some do use them in practice. However, many forego these approaches, reporting difficult training methods and mixed success. To behavior analysts, this comes as no surprise, as we have some idea that increasing and maintaining response dimensions is a process that can be sensitive to how feedback is delivered. Recent behavior analytic research has explored using SEMG along with feedback manipulations as a means to increase the magnitude of maximal voluntary isometric contractions in a clinical context, offering a potential advantage over standard verbal encouragement. The result of these investigations is a strategy known as the Reinforcement-Based Maximum Voluntary Isometric Contraction Strategy, or RMVIC. The strategy relies on a pattern of responding in which the removal of a historical reinforcer results in a transient increase in rate and or magnitude of responding before eventually decreasing. It's commonly known as an extinction burst. Our aim for this study was to investigate the RMVIC strategy on the tongue press response. With a focus on internal validity and proof of concept, we recruited 3 healthy participants with no dysphagia-related medical history. Following consents in relevant forms, participants were asked to sit upright in a chair. Muscles were located via palpation, and the flex dot was placed under their chin via medical electrodes placed directly on the skin over the suprahyoid muscles. From the user interface, we could set the magnitude criterion for audio feedback here. We conducted a brief pre-training wherein the participant is instructed to press their tongue to the roof of their mouth while we observe our data stream for movement. Our independent variable was the RMVIC strategy, which I'll describe in greater detail. Our dependent variable was the suprahyoid contraction observed during the tongue press exercise, and we observed the peak amplitude of the SEMG waveform to determine the magnitude of that response. The RMVIC strategy consists of 4 trials. Prior to the start of the RMVIC phase, participants are instructed, during this phase, when you flexed hard enough, you'll hear a ding. The ding is the goal. Trials 1 through 3 will involve easily achievable feedback criteria based on baseline observations. During trial 4, no feedback is available, so no matter how hard the participant presses their tongue, they won't hear a ding. To account for this deception, participants were debriefed following the experiment. During the SVE phase, we provided this instruction. When you hear the word flex, flex as hard as you can. We also informed the participants during this phase there will be no feedback. We used a single case counterbalance reversal design with each subject exposed to all faces acting as their own control. Again, each phase consisted of 4 trials and was guided by automated flex and relax prompts. Following the prompts, participants had 3 seconds to respond. Following the relax prompt, participants had 5 seconds to rest and prepare for the next prompt. Between each phases, participants had about 3 minutes to rest to reduce the effects of fatigue. The results of Experiment 1 were analyzed by comparing fourth trial performance, which is the procedural extinction trial, between the SVE and RMVIC conditions. As shown, analysis revealed that all 3 participants produced stronger tongue press contractions following exposure to the RMVIC strategy compared to the SVE strategy. In subsequent graphs, you'll see magnitude in microvolts along the y-axis and trial count along the x-axis. The jagged lines you see are waveforms, the dashed lines are the feedback criteria, and the x's indicate the extinction trial. Here are the results for participant 1 showing higher peak magnitudes in the RMVIC condition. Participant 2 was counterbalanced to the SVE condition first. Still, we see those characteristic fourth trial increases in response magnitudes. And again, with participant 3, we see the characteristic extinction burst effect in trial 4. Individual participant analysis showed consistent benefits of the RMVIC strategy. Participant 1 demonstrated a 90% increase in contraction magnitude under the RMVIC condition relative to SVE. Participant 2 exhibited a 129% increase, and participant 3 exhibited a 192% increase. The average participant increase across participants was approximately 137.5%. A primary limitation of the current study is the sample size, which is considered small by medical research standards. Although SEMG measurement of the suprahyoids has been previously validated for this purpose, another limitation is the reliance on SEMG recorded at the submental region without simultaneous direct measure of tongue press output. Although electrode placement was standardized and response topography was carefully controlled during pre-training, future research should incorporate ways to quickly validate and individualize non-invasive measurement systems. Finally, we used healthy participants as a proof of concept. Participants suffering from dysphagia will have individual differences that must be addressed. Future research should extend this work by evaluating the RMVIC strategy on those diagnosed with dysphagia. Investigators should also continue to explore the extent which increased lingual pressure results in direct transfer to functional swallowing outcomes. But finally, collaboration between behavior analysts, speech pathologists, and other health professionals is critical to advancing our knowledge related to this issue and many others. Despite the limitations, the results suggest that reinforcement-based biofeedback strategies may provide a superior method for assessing the maximal contractile capacity of the muscles involved in tongue pressure generation relative to standard verbal encouragement. This has implications for dysphagia assessment and other treatment, and may also be useful in other oral motor deficits. Thank you so much for your attention and for recognizing this work. And if you'd like to connect, please feel free to use this QR code and reach out anytime.